Yeah, so we've learned a lot about diffuse large B-cell lymphoma over the past several years. It goes back to the recognition that really this is not a single disease entity, but actually represents multiple different types of lymphoma that collectively are referred to as diffuse large B-cell lymphoma. More specifically, it's been recognized that there is one type called germinal center subtype and another ABC subtype, which have different biologic features and different outcomes, with ABC subtype having worse outcomes than germinal center subtype. Over the past couple of years, we've come to identify that this is really an oversimplification of the subtyping, and with more advanced molecular tests, next generation sequencing, and high throughput genomic analysis, two separate groups have independently identified diffuse large B-cell lymphoma as really having a number of different subtypes. And germinal center is actually can be divided into two different groups with worse and better outcomes. And similarly, the ABC subtype can be divided into at least two or more subgroups, some of which have better outcomes than others. But from a practical perspective, I would say in 2020, we really approach most diffuse large B-cell lymphoma the same way, with the notable exception of double hit lymphoma, which is probably a germinal center derived subtype of diffuse large B-cell lymphoma that tends to have a more aggressive course. The question about initiating treatment before receiving the cytogenetic results is an important one. If you know that a patient has diffuse large B-cell lymphoma and they need immediate treatment, the standard of care still is R-CHOP chemotherapy for frontline therapy outside of a clinical trial. If we don't have the cytogenetic results to know if a patient has double hit lymphoma, it's still reasonable if the patient has a clinical urgency to initiate treatment with R-CHOP and then potentially escalate to more intensive regimens, such as dose-adjusted R-EPOCH with subsequent cycles. So turnaround time of getting these molecular tests back can be shorter or longer, depending on if you're the patient is being seen at a high volume center or a community center. Many community centers send out the FISH tests for MYC, BCL2, and BCL6 translocations, and there may be a longer turnaround time. But again, I wouldn't let that delay prevent me from initiating treatment. If there was a clinical urgency to start therapy, it's perfectly fine to start with R-CHOP and then subsequently change after you have the results of those molecular tests.